Hey team, let's jump into the fourth part of our conversation on vascular and lymphatic patho conditions. We are talking now about lymphedema. Okay, this is like a whole practice area, honestly. If you're really interested in this, hit it hard when you come to your second year integumentary cardiopulm content, and then let it just carry your career forward. This is a really fascinating specialty area to treat. So what is this? Well, it's a dysfunctional lymphatic system that causes a buildup of lymphatic fluid in the body and profound swelling. Over time, you get skin and tissue changes. So how do you get there? Well, there's something wrong with the lymphatic system. Something is wrong usually with its structure, and either it doesn't develop correctly or it becomes damaged over time. So primary would be something that a person is born with, which honestly isn't very common. Secondary is usually more of what you're treating. So sometimes in different forms of cancer, they will remove your lymph nodes as part of preventing progression of it into like stage 4, right? Otherwise, you can have infection or inflammation of lymphatic structures or some sort of obstruction of lymphatic structures. In combination with CVI, this leads to a lot of impaired movement of fluids across the body. It's not rare, actually. Approximately 3 million cases in the US, and for all I know, that data is old and it's higher now. But you'll see this pretty often, again, because of its concurrence with obstruction or fibrotic states from a tumor or radiation rationale. You're going to see a lot of lymphedema specialists in an oncology setting. So a really powerful specialty area to work in. So a gentle review of the lymphatic system so that its pathology makes more sense. There are 3 primary functions of the lymphatic system, and I'm being reductive here. It does more than this, but here's what we're going to focus on. So the big one, the obvious one, is that it has to do with your fluid balance. So it moves fluid into your venous system so that you can eventually excrete it via the kidneys. And so by that, it keeps your interstitial, in other words, the fluid between your organs and other guts and structures and things, it keeps those volume levels balanced. It also has immune function. It actually brings a lot of adaptive white blood cells into your lymph nodes, which is why they swell when you get sick, and then they can actually enter your bloodstream and go to where they need to do their job. And then less famous, but still important, is its role in digestion. So it transports fatty substances and fat-soluble vitamins from your GI tract into venous circulation. But really, the big thing we're going to focus on here is that it's supposed to collect and transport fluid from those interstitial spaces back into venous circulation. When it can't do that, that's where you end up with the condition. And it's worth noting that the fluid that it's grabbing is protein rich, okay? We do want to keep in mind that that is protein rich. That's actually important for the pathology or the pathophysiology. And then just to give you a sense of where this plays in terms of your overall physiology, is the thing we don't really talk about as much is that you get this beautiful image here of like the veins returning blood, swapping out CO2 and oxygen at the lung, and the heart sends it into the periphery, and as well as like your organs and brains and all that. But the lymph nodes are like right there. Here they are in green, just kind of as part of the system there. And they're kind of maintaining the balance via pressure. So there's like some kind of chemistry, physics stuff going on here. And it's worth noting that you do have a lot of lymph nodes. They're all over your body, and they're just right under the skin, right? So when the lymphatic system is compromised for some, whatever the reason is, the etiology is, you end up with an overload of fluid within the lymphatic system. And because it is protein rich, you end up with increased osmotic pressure, and the protein being a solute, in other words, a thing that's dissolved into the water of that lymphatic fluid, it draws more water in. So you end up with this issue of there's already a problem and it's compounded by physics. So this accumulation of extracellular fluid and proteins over time causes a proliferation of adipose tissues. So as the condition progresses, it goes away from just fluid buildup to changes in the structure of the tissue underneath the skin, in which there's more fat tissue, and then the skin itself starts to change over time, which leads us to our presentation. So I'll jump ahead here so you can see the presentation. So this is lymphedema, okay, in its different stages here. These images here on the right. Here's stage 1, in which you can see there's just a change with swelling, right? Over stage 2, you start to end up, this limb has it here, you end up with some of the more adipose tissue buildup as well as swelling, and then over time, a lot of things change, and now we start to enter territories in which the skin is drastically changed and it becomes more fibrotic and thicker, okay? So let's come back here so you can see the presentation again. This is edema to dorsal extremities, particularly over the foot and hand, the top of the foot and hand, the dorsum. And you'll end up with something called stemmer sign, which is here. So this is where you can actually pinch at, kind of see the base here of the toes, and here almost all the way down to the MCP of the fingers. You can pinch and you'll successfully pull up like a little bit of fluid, okay? So that's what you're seeing here. This is negative stemmer sign. That would be positive stemmer sign there. So basically stemmer sign is just the presence of edema at a distal extremity. You'll also get dependent edema. That's edema which gets worse when the limb is down. So in other words, if you're sitting in a chair and your feet are on the ground, your feet and your limbs are in a gravity-dependent position, and edema which forms in that state is called dependent edema. And then you'll get pitting edema, which is the indentation of the skin. So you have kind of an anatomy, a geography, as well as a type of edema. It can occur to other places, but it's most iconic for the legs, to be honest. Hands as well, for sure. I don't want to discount that, but it's usually particularly known for the lower extremities. Over time, you end up with issues on the movement of blood in different areas, and you'll get a hyperpigmentation. And then over time, you end up with these fibrotic changes because this becomes a chronic inflammatory status, and you get decreased elasticity of the skin and kind of a buildup of fibrotic tissue. And that's when the skin becomes tougher and kind of, not thicker per se, because there's more, it's more complicated than that, but it feels thicker. Because these limbs get heavy, these patients often complain of tiredness and fatigue in walking. Varicose veins start to happen because now the lymphatics are backed up, but they're maybe trying to dump more into the veins, and so you can have CVI in addition. Weeping edema is iconic in this condition. This is edema that is so profound that it extravasates out, and it actually comes out of the skin. You can put a towel under this person's feet and it will become soaked with a clear yellow tinged fluid that's it's got a salty smell. It's iconic. If you're walking down the hallway and a patient has weeping edema, you'll smell it from the hallway. So like even right now, it's been a few years since I smelled it and I can still recall it. It's a quite notable smell. They'll have sensory disturbances because what you've got is a spreading out of the skin as it's swollen. And so you have fewer receptors, and so they won't register touch as well. And then the stiffness and limited range of motion start to kick in. And then with all of this in combination, this is an important one, you're going to have a patient with decreased resistance to infection. Why? Because lymphatics aren't able to transport the immune system cells as easily, and you've got fluid that's staying still. So that becomes an easy hotbed for bugs, basically. So this is staging that you will learn in your second year. I'm not going to ask you anything on here, but what I'd like you to do is take a look. Note that first we have some edema. We don't have fibrosis yet, but the edema gets worse. And then we start to get fibrotic changes, and then we start to get skin changes and infection. So basically, think about the pathophysiology that leads to the progression, and that's what I want you to know. As the staging increases in severity, what is the pathophysiology that's leading to the manifestation of each increase in severity? That's what I want you to think about and to know, okay? So again, we come to the presentation where you've got kind of the stage 1, stage 2 territory coming into stage 3, and then stage 3 into 4. So stage 4 would have the much, much thicker skin that we talked about. Oh, sorry, it's stage 0 through 3. My apologies. And this is when you have the one that you may have seen in the community, the elephantiasis, in which the skin becomes much, much thicker and very dry. And that's the status right here. So it's iconic for that. What do they do in workup? I'm not going to ask you anything on this slide because this is second year material, but I will familiarize you with it. And that basically you're looking at the skin, you're seeing how swollen everything is, and you have a lot of different ways to do that. So this is really interesting, including bioimpedance testing. So this used to be really popular at certain gyms in which you do a handhold bioimpedance monitor device, and you could see what your body fat percentage was as an estimate by that device. Now they're using it more for an application of how much fluid is in you, and that gives them a very good sense of how your lymphedema is in terms of has it gotten worse or better. So that's kind of cool. However, this is much more important. So in lymphedema, what we really want to be good about is education. So CLT, or certified lymphedema specialists, are really, really good at this education. So these are general education findings, and these are yellow flag findings, okay? So we've got here is that they need to stay clean and they need to apply lotion. The health of that skin is not perfect, so they need to help it out. Don't let it crack, basically. So that's the logic of the lotion. And then because the immune activity isn't as excellent, they need to make sure that it stays really clean. They need to be gentle if they wash their hands and they're drying, gentle but thorough. They need to be very careful with their nail care. They can't cut their cuticles, okay? So no more going to the salon and getting your nails done with the cuticle cutting, okay? That's contraindicated in this population. If they do get a cut, they absolutely need to clean it with soap and water. They need to apply an antibacterial ointment that's been approved by whoever their providers are in that area. So that's going to be the physician or maybe the CLT. And then they need to apply a dressing, a sterile dressing of some kind. Sunburns are a real issue for them, so they need to avoid sunburns. They need to be good about wearing sunscreen. Is probably going to be a little tricky for them logistically, so I would actually say they need to wear proper clothing that provides that skin protection against UV radiation. If they like to garden, this is actually a risk because there are bugs in the soil. And while it's not a problem for somebody with a typical immune status, they are a little bit immune compromised. They need to wear gloves because they can't risk getting like tetanus from the soil or something. Yes, that is a thing. If they like to shave, they need to switch to an electric razor or electric shaver, not a typical one that's non-electric, because you're more likely to nick yourself, and they really need to avoid getting cuts. Extremes of temperature are not their friend because they can't regulate their capillaries like a typical person, so hot and cold packs, not a great idea in this population. So extremes of temperature are not their friends. So no more scalding hot showers, hot tubs, stuff like that. If they have one arm with lymphedema and one arm without, the unaffected limb is where they need to have blood pressure done, their blood draws, and all of their shots, okay? That's an important safety thing. So, okay, so red flag findings. On a patient with a known lymphedema diagnosis, any presence of redness, warmth, tenderness, or rash is a call the physician. In fact, depending on what they've got, it might move into a gentle red flag and that you don't necessarily need to call 911. Type thing. It's not that territory, but you can't treat them for that day. Like PT is contraindicated. So if they have an infection to the skin, PT will cause increased blood flow, which means if they've got cellulitis in the skin, the bug might successfully make it into the bloodstream, and that would be a sepsis risk. So that's why cellulitis is sometimes in combination with lymphedema, cellulitis being a skin infection, that might be a reason you don't work with a patient. It doesn't mean, again, that it's an emergency. It just means that PT is not a good idea because we make them move, we make their blood flow, and we might cause seeding. So that's something to consider. And then any sort of new onset of swelling in a joint or limb that doesn't resolve in a day or two, go see the physician. So they basically have to be super careful with their skin. You know, it's pretty serious. Okay, PT treatment. I'm just going to gently touch on this because it makes sense with the pathophysiology. Similar to veins, lymphatics have one-way valves, and so a lot of what you're doing is trying to do something they call decongestion. So using specific manual techniques, they manually drain the lymphatic system, and then they keep it from getting swollen again, and that's the compression therapy, okay? So there's no actual cure for lymphedema. There's only really good management and prevention of exacerbation. So with any luck, it gets better over time, but a lot of what you're doing in this form of care is getting the lymph nodes to a good state, the lymphatic system to a good state, and then keeping it there and teaching the patient how to keep it there. So the treatment is very effective. You just have to get there. So it's pretty challenging. It's really cool too. I've taken some CEUs on this, and I actually use the skills quite a bit with my patients who get swelling due to neuro conditions. We'll talk more about that as a secondary or tertiary problem in neurorehabilitation, and I have found the manual skills I learned from those CEUs to be very helpful. It makes me surprisingly effective. So a good area for learning a few skills, even if you don't necessarily go into that area. I've also actually used it with my my athletes, not that I have very many of them, but my athletes as well as my trauma cases, because, you know, things get swollen again. How do you end up with swelling? Sometimes it's mechanical damage or trauma damage to the venous or lymphatic system. So I found that that's made me surprisingly effective in that area. Okay, so what can they do on the management side for the surgeons? Well, they can try to do bypass. If there's one particular region of the lymphatic system that's not doing well, they can try to bypass it, similar to the logic of arteries or veins. They can kind of graft over a lymph node, or they can try to get some of the adipose tissue out of the way, and actually liposuction might be a good option there to help allow the lymphatic system to work better. Even if you do all of these, you still will end up seeing a CLT and doing the compression therapy logic. So CLTs are really, really close with the surgeons they work with. It's a really good, it's a nice professional working relationship, very interdisciplinary. And then it behooves us to note, so in cancer, and the classic cancer type that tends to have a high lymphedema incidence is breast cancer. Why? Because you're having to do surgical work near huge nodes. So see these little dots here? These little circles, those are lymph nodes. And the larger lymph nodes that receive a lot of stuff are in the axilla or the armpit. So sometimes when they're doing a mastectomy and they remove this tissue, they end up removing a sentinel node here in the axilla, which means that out here the limb is very prone to getting lymphedema. So 1 in 5 women or individuals with breast cancer who survive develop lymphedema simply because of the surgical management. So what that means is that individuals with that diagnosis of post-mastectomy status with lymph node resection or removal really have to work closely with their physical therapist to make sure they don't experience these secondary outcomes. So the shoulder becomes immobile, it becomes weak, their posture gets strange, and they have real issues with fatigue, and it's upsetting, you know, because it's a lot of scar tissue that can build up, and then the lymphedema issues as well. So where I was coming from, like if you come from a state that's like got a lower population than Texas, there are almost no CLTs. So coming from a state that's more rural, prior to moving back to Texas, where I'm originally from, I can tell you that Arkansas has almost no CLTs. It was actually an issue. So in the big metro areas, and there's only like 2 because it's a rural state, there were a few, and they were booked within as soon as they started. So if you're looking for really good job security, becoming a CLT is a really good option. Oncology is one of the fastest growing disciplines in PT, and your patients will absolutely adore you. It's challenging and it's really rewarding. Okay, let's go ahead and pause here, and then we'll move into our last 2 diagnoses in this particular area.